non-invasive shunt irrigation. So this is Dr. Robinson, who works at University Hospital as a neurosurgeon and sees all sorts of different kinds of conditions. But today, so he's on call, and he just got a call from the emergency department saying this 4-year-old just came in complaining of a headache, fatigue, and it's kind of nauseous. His parents have noticed he's not kind of acting like himself. And normally this wouldn't be a reason why the emergency department would call neurosurgery first. But this case, the patient has a shunt, so that leads the emergency department to be a little concerned. Let me stop and explain what a shunt is first and foremost. It's a device that a neurosurgeon implants into a patient who has excess of fluid in their brain, is having trouble doing that on their own. So this is how it works. I actually have a dummy up here that is kind of more live. But it's a catheter system. The catheter goes into the skull, into the brain, and then comes out of the brain, goes over the skull but under the skin to a valve component, which allows the neurosurgeon to kind of control how much you're draining. And then continues to tunnel under the skin, over the rib cage, and into the abdominal cavity. And that's where the nutrients can be like reabsorbed, so it's wasted. But as a lot of neurosurgeons put it different ways, but this I thought the best quote was that these are the bane of every neurosurgeon's existence. It's such a pain for them to deal with because these clog, and they clog very frequently. I talked to a patient who had 49 brain surgeries over the course of 2 years just for revisions, just to clear those clogs. So they're very prone to this. The biggest problem with this is it's such a pain to diagnose those clogs, even though this is just below the skin. And really the only thing to test is brain surgery. So really what the neurosurgeon is dealing with is kind of like a game of Wheel of Fortune, where you're doing kind of an X-ray and CT scan, and maybe you get a little bit of information, but you're continuously trying to get at an answer, solve the puzzle, but you just can't get there. And you're continuously doing more and more kind of invasive tests. At the end of it, you're looking at this, and you really just can't make anything of this. And so as a neurosurgeon, you're forced to kind of consider brain surgery, even though you're not sure. And nobody wants to go there, but sometimes they're forced to do that just to get that answer. So most of these patients end in the hospital for something like 9 days. This is the average data, and about $35,000 to spend on this test just to get that answer. This isn't something that happens every once in a while. The neurosurgeons I spoke with said that they had already seen like 2 to 4 of these patients any given week by the time I spoke with them. So there's a lot. This is a huge resource during the hospital. So what I've worked on for my thesis is we've got doctors need a tool to help them make decisions faster, cheaper, and much more confident about patient outcomes. So really kind of what are the pieces that then allow you to finally put enough information there that you can solve the puzzle. This is my computer that is my so the direction that actually, oh really? Okay. Well, that's out of the organization. So the direction, this need came out of the team that I worked with last year, and the direction we saw as an opportunity was ultrasound. Because for 2 reasons, because the information that can be made available, information about what's happening inside the body, anatomy, and also the behavior. You can see a baby, and you can also see the baby's heart. So the kind of information you can get is great for this situation, like the shunt. And it's also, there's a very low threshold to using this kind of device because it provides very little risk to the patient. It's not invasive and there's no radiation. So there's really not much of a hurdle to jump over to get to this. This would be the first test that's done when the patient gets to the hospital, without a neurosurgeon at 9. So what I focused on my thesis was how we could leverage ultrasound to provide the information that the neurosurgeon needs. Really focusing on this neurosurgeon as the user. I spoke with quite a few neurosurgeons at 3 institutions in the area, really learning about what are the questions they're trying to answer throughout this process, and how can ultrasound give them the information and help to visualize that. So really kind of focusing on 2 areas. I did a lot of prototypes, and they're all there rather than talking about them after. But kind of half the prototypes are about data and extrapolating information from the prototypes, from what the ultrasound can get in order to give information to the neurosurgeon. And then kind of half of them were more about visuals and showing the neurosurgeon what's happening inside. Ultrasound is capable of kind of doing both of these things. But overwhelmingly, neurosurgeons prefer the visuals. They respond much more to visuals and are more trusting of them. But this posed a key problem. that as one neurosurgeon described to me, there's turf in the hospital, and doctors can't cross each other's turf. And if you're using ultrasound for imaging, which visual information ultrasound would be, you're now on the radiologist's turf. So now what the workflow of this device would have to be would be a radiologist using it, and a neurosurgery then going into the patient's file and seeing what the radiologist pulled from the patient with the ultrasound device. So really what you now have is a radiologist who understands ultrasound and a neurosurgeon who understands shunts trying to communicate. The neurosurgeon isn't in the room when the test is being run. So this is the shuntoscope, my solution, and really it merges the neurosurgeon's needs with the radiologist's workflow and your mental obviously ultrasound. So this is the device that's useful for both of them. And it's really a probe that fits in with the radiologist's current machine. And then the interface is designed for the monitor that the radiologist looks at, and the dashboard down here that allows you to control things on the monitor. So this is the main interface of the shuntoscope. And the first thing you'll notice here is this. Your attention. So that is the cross section of the catheter. So this is I took the ultrasound probe and put it here. And kind of took a look inside. So this would be the cross section of what's right below, as well as the red and yellow represent the flow of what's going through, the velocity of particles coming through. And the reason I visualized it like that is because the current benchmark is that during surgery, a neurosurgeon will take the catheter and actually disconnect it from the shunt and watch the flow that's coming out, as well as look inside, maybe it's an endoscope in there. And so this matches what they're used to looking at, and using that to do the diagnosis when they're in brain surgery. We're doing that non-invasively. But I also gave them flow in this way too. This means nothing to them clinically right now because they have no way of measuring this currently, so they don't have an idea of what a good flow rate versus a bad flow rate is. This is giving the flow and flow over time. So the reason I gave this to them is overwhelming neurosurgeons saw future in-shunt diagnostics in this space. Is if you would start to track this information, you would learn what's good flow, what's bad flow, and how we control shunts in order to have patients heal faster with these devices. And then lastly, this is kind of a map for the radiologist. A neurosurgeon knows that you can expect to see where you expect to see clogs, but a radiologist doesn't. So one of the things that the probe does is wherever you place it, it takes a scan of the entire catheter from brain to abdomen and shows you where there's more tissue, where it's more white, and less tissue, where there's black, so you can get an idea for where those tissue blockages are within the line and direct your attention to those places. So as a radiologist using this, you would kind of pull up the dashboard and maybe capture a video of what the flow looks like and save that to the patient's file. And this is then what the neurosurgeon gets access to, and that kind of comes out in a GIF format that they can then look at the flow. You can also go to another location and take flow as well and start to really gauge what's going on inside and collect the data from that flow that's going along the bottom here. In addition, if you find the color distracting, you can take away the flow and just start to look at the blockages. And now that they've taken the flow information, they kind of move the probe around and take a closer look at where the blockages are. But the problem is, so my first attention would go over there and try to look there, but that is actually inside the skull. So what do they do then? Well, they can put the probe, one of the features of a shuntoscope is you can put the probe kind of here where you have access to the shuntoscope, and then extend your view and actually ask it to look farther into the skull, where you can kind of see this blockage that you may not have seen otherwise from the outside. So now you can save that, and as a neurosurgeon, we look at this and you look at these, first the flow, and you say, is the flow good? And that says there's a problem or there's not a problem. You correlate obstructive flow to the symptoms of the patient, and then if you decide that obstructive flow is the problem, you can look at these blockages and start to gauge, what's your surgical strategy, which of these look problematic based on what you're used to seeing during surgery, and so which ones do you plan on operating on, and how will you do that surgery? Because if it's just in the abdomen that you think, you could just open this incision instead of going into the brain, and it's much less invasive surgery. So this presentation. So when talking to my users, I talked to a mother of a patient called Samantha, and she said that the shuntoscope really cuts to the chase and is safe. So she would overwhelmingly want her neurosurgeon using it, she would actually choose a hospital according to that. She already choose a hospital according to neurosurgeons there. So I'm going to SHUNTOSCOPE and do that. I decide after. And then also for the Dr. Nordstrom, he wants to yeah, I can get a little prototype. And that's something I can talk about too, the feasibility of it. So again, I'm going to be prepared to talk about that. So overall, the SHUNTOSCOPE is familiar to radiologists, answers the questions of neurosurgeons, and it's really versatile across patients. It's not going through a checklist of information. It's providing kind of a platform that the neurosurgeon radiologist can communicate across and really talk about what their protocols would be and measuring